Okay, good morning, everybody. My name's Bob Fryatt. I'm the project director for the Health, Finance and Governance project, and I'd just like to welcome you all here this morning. The Health, Finance and Governance project and the Assist project, and it's nice to see Rashad, my fellow project director, here today. I've been working for the last few years with USAID, with various country leaders and thinkers about the issue of governance and improving quality, assuring quality of health services. And we're here for this morning to hear the summary of some of that thinking. I'd like to give a special welcome to Vivian Ado-Kabaya, who's come from the Ghanaian National Health Insurance. Thank you very much. No, please stay with you for a moment. Yeah. Just giving you a special welcome because you've come so far. And Paulina Pacheco Estrello, who's come from the Mexico Ministry of Health. So again, thank you very much for taking the trouble to come see us, be with us this morning. And we'd like to get going fairly quickly because time's quite tight this morning. And the first speaker is going to be Jody Charles, who's a Senior Health Systems Advisor for the USAID Office for Health Systems. And Jody's been sort of working with us and overseeing this work for the last few years. And then after that, we'll have a few questions from the audience and also for online. People online, please send your questions through the chat function. And then we're going to have a second speaker from Shams Syed, who's the coordinator for Quality Systems and Resilience Unit in WHO Geneva, and he'll be talking to us online, we hope, if the technology works okay. But to get things going then, I'd like to sort of welcome Jody to the stage, and I look forward to your questions after her first talk. Jody, over to you.
Thank you, Bob. Good morning, everyone. Can you hear me okay? Very tall. I have to move the microphone down. So first of all, I want to thank everybody for showing up here today. And also thank you to all the people who have been a part of this effort for the last couple of years. Is there something I do with PowerPoint? If not, I can talk with, I don't think anybody ever died because they didn't get a PowerPoint. Do I do anything with it or? Okay, it's not a big deal. So first and foremost, I want to thank the core members of the team that have been leading this effort from the beginning. We have the HFG project, we have the Assist project, and we have our colleagues at WHO. But more than that, this work really came out of dialogue and effort that was raised by the JLN member countries. They really brought this issue of quality and governance and, and how do we build more, oh, it was right in front of me the whole time. How do we really address these core intersections between quality and institutional arrangements, and how do you improve governance structures for better quality? But then likewise, when we're having dialogue around risk pooling and financing, how do you make sure that quality is not just sort of something we think about, but is actually a central component of that? And so really, that was really the JLN member countries who were pushing for that. So we greatly appreciate them keeping us honest and moving forward. So this really, and I can't believe it's been 2 years because it feels like it was yesterday. We convened a group of stakeholders in Tanzania in March of 2016, and it was really a wonderful collaboration. And it was. I learned a lot from this. First of all, we sort of think of ourselves as being systems people. We all think systems thinking. But we had people who were governance experts and quality improvement experts and financing experts, and it was really interesting to see actually how diverse and differently we think about things. And that was really an important dialogue, and we recognized that we needed to be much more deliberate in how and where and when we talk to each other and communicated in a much more systematic way. So the March 2016 meeting in Tanzania was really kind of launching this dialogue. And the team came up with these 8 stones. I love that term. I don't remember how the term, was it Shams? That's these 8 stones, like pearls of wisdom, I guess, stones of genius maybe. These 8 components that we really need to think about in a very deliberate, robust way if we're really going to try and sort of crack this this nut and think about systems in an integrated way. And this really aligns with how I think globally we're moving forward. We need to kind of remind ourselves about the systems and health systems that we can get very siloed even within systems. People very driven by financing or quality or information systems, and we need to really make sure that that we integrate systems thinking in a better way. So these 8 stones and this kind of thinking kind of germinated and kind of grew for another year, and through that developed this guidance around the 8 stones. And then we reconvened a group of stakeholders, some same people, some different, in August of 2017, where the group furthered this work in developing a consensus statement, a global research agenda, and a guide, which is being piloted in Ghana this month. We're very excited about it. Lisa's smiling in the front row. The Ghana mission was really interested and intrigued at the idea. The USAID mission was intrigued by this, and when they realized how centrally the Ghana Ministry of Health was involved, they were even more excited. So we're really looking forward to that. We really, as with all these kinds of things, the core projects have been, working on this for a couple of years. They are, unfortunately, HFG and Assist are ending this fall, which is always sad. But the upside of this is that this body of work has really germinated, kind of seeded some really good structures and sustainable dialogue that we hope, we expect will continue on. We will continue our work with the WHO, which has been a wonderful collaboration. You're going to hear from Shams, I think, in a minute, and the Learning Lab. And again, really, the Joint Learning Network has been such a group of leaders in driving this, and so we look forward to those group of stakeholders continuing this on. And the community of practice that's been established is a continuing sort of venue where these issues can be discussed and expand on it. So from our perspective at USAID, we've really viewed this as being an incredible progression of a collaboration that didn't, sort of nascent, but really needed to be fleshed out and be much more explicit. And we look forward to that continuing, and I'm really excited to hear the dialogue that's going to go on today and hopefully give us some ideas about where to continue to take this forward. Thank you. Sure.
So before any questions for Jody or about this initiative or today before
I don't want to leave prematurely, but...
No? Okay, all clear? Okay, right. Got away with that, Jody. Well done. So next we'd like to invite Shams to say a word. I am being told that he's online. Shams, are you with us? Okay. No. Shams, welcome. We can see you clearly.
Hello there. Can you hear me?
We can hear you clearly. It's all working.
Wonderful.
Well, thank you very much for joining us, and over to you.
Thank you so much. I shouldn't sound so surprised that the technology is working, but it's a real pleasure to be with you all, and I certainly wish I'd be there with you physically. But I've just been asked to give just a few perspectives on the joint journey to date, but also to give some perspectives on the current status of the work on quality, specifically as it pertains to universal health coverage at WHO. So just wonderful to see Jody articulate our journey over the last couple of years, and I think it is important to emphasize that small groups, small teams that can come together and germinate some thinking is often underestimated in terms of how that can really contribute to the global pool of knowledge on a subject. And I think really that this is an example of how that can happen. I'm just going to cover 4 quick points here. So the first, I think many of you have been following the linkage of our new Director General. I can somehow still manage to say that he's new because we had the World Health Assembly, which just was completed the week before last. And I think it's important to emphasize that the strategic direction of WHO is really focusing in on promoting health, keeping the world safe, and serving the vulnerable. But I think many of you are familiar already with the triple billion aims, and that's a real articulation of our way of working and way of thinking for the coming years. And one of the billion aims is related to universal health coverage, as I think most of you will know. Importantly, the other 2 billion aims have a clear interrelationship and linkage with the work that we're talking about today. So for sure, when we talk about addressing health emergencies or promoting healthier populations, the 2 other billion aims, the work on quality, the work that links quality with universal health coverage, the critical importance of the governance piece in this becomes clearly evident. And within that context, WHO is, of course, a servant of all countries of the world, and our emphasis in the next phase, 2019 to 2023, will be really driving public health impact in every country. And that means being nimble and being able to adjust to the realities that we face. And again, you will see this is an open document within the general program of work, is our focus on policy dialogue, strategic support, technical assistance, and in some cases, service delivery. So those 4 blocks, 4 types of country-focused efforts really are important to put forward, especially in the context of governance of quality. So coming to my second point, again, some of you know that this year is a year of many global reports. But the first one that was made available during the World Health Assembly is a joint publication of the WHO, World Bank, and OECD, really emphasizing the critical linkages between quality and universal health coverage, and really emphasizing quality as a global imperative in the work on universal health coverage. And importantly, this has taken some time to develop, but it is a manifestation of country wisdom that then percolates the global dialogue and architecture around the subject. And I would encourage colleagues to have a glance at that, specifically the call to action, which is addressed to governments, to health systems, to citizens and patients, and to health workers. And within that, of course, the first point, the call to action to governments, really emphasizes the critical importance of national quality policy and strategy. And then that will take me to my third point related to national quality policy and strategy. So again, I know many of you in the audience have actually really been incredibly helpful in helping us think through this work, but you will know that in a couple of months ago, a WHO handbook on national quality policy and strategy was issued, and it was something that was co-developed with countries, including the 2 wonderful colleagues that are with you in terms of Ghana and Mexico. So this work really emphasizes the importance of co-developing with countries the thinking related to national quality policy and strategy. It also allows us to think through how this can be taken forward both in low and middle income countries, but importantly in countries across the world. It identifies 8 key elements, and it is important to emphasize a couple of those elements. So the one that really jumps to mind, especially in the governance space, is the critical linkage between national quality strategic direction and overall health priorities of a country. And this is particularly related to the point that Jody was making in terms of how we can also be victims of being siloed in our own space. So that's a really important point, which is articulated very clearly in the handbook. Another important point is looking at the local definition of quality through effective stakeholder engagement throughout the process. And I think this is also very aligned with what Jody was highlighting in making sure that country truths check us in our thinking when we are working together on the governance issue related to quality. So the National Quality Policy and Strategy Initiative will provide us a really interesting opportunity to continue to move forward together and continue to learn, because this is a space that needs significant learning. And within that learning space, particularly the issue of improvement methods and interventions becomes important. Particularly the linkage with quality indicators and core measures becomes important. And the body of knowledge on this subject area is really moving forward, and moving forward quite rapidly, giving us an opportunity to really think through what the countries are prioritizing and how they're prioritizing that, but also in line with the overall UHC monitoring frameworks that are now evolving quite rapidly. So that brings me to the final point, which is related to the learning agenda. So Jodie already mentioned the critical importance of the Joint Learning Network and other learning mechanisms, both nationally and globally. For us, we emphasize, and I think we'll be in light company today, the critical importance of learning at the very local level. So there is really no global learning agenda unless we can speak of the local learning agenda, and it's very local when it comes to quality in terms of really small teams working on quality at the facility level or at the subnational level, specifically using the district as our unit of analysis and intervention. So for us within WHO, we do have the Global Learning Laboratory for Quality within the context of UHC. We're delighted that we've been working very closely with the ASSIST project to make that a reality and create that foundation. But it's an opportunity to really build the knowledge base related to specific subject areas. And just very briefly, the three big blocks that we really think about in terms of the learning. The first is actually national quality policy and strategy. The second is the linkage between wider quality and specific technical areas such as maternal and child health, or water, sanitation and hygiene, or infection prevention and control. And then the third is really focusing in on the concept of compassion and the linkage between compassion and quality of care. This really affords us an opportunity to keep that learning journey active and alive. And I'd just like to introduce the concept of being humble within that learning journey, because specifically in the quality governance space, I do think that we have a lot to be humble about, because we do have lots and lots to learn, and we hope to learn about that together. So again, thank you so much for allowing me to make some points early on in the day, and I'm really looking forward to listening to the colleagues throughout this special event. But thank you, Bob, and back to you.
Thanks, Shams. Before we go into our panel event, any questions for Shams? Points to raise? Could you say who you are?
About how the quality of care network with the 9 first wave countries is connected to this policy initiative, because they're both within WHO, and I didn't hear anything about them in this. So just wondering about the connection.
Hello. I missed the first part of the question, but if I'm understanding correctly, it's the linkage between the quality of care network for mothers and newborns and the work that we're doing on national quality policy and strategy. Am I correct?
Yeah. Yes.
Yeah. Yeah. Okay. So time won't allow us to go into the details on that, but really we are connected at the hip. So in the design of the quality of care network with our colleagues in the maternal child health department, we have always emphasized the critical importance of specific Pathfinder activities related to quality and overall quality directions that a country takes. So again, coming back to the countries as an example, Malawi, for example, is one of the countries, as you know, that is a part of the quality of care network, and that's where the most recent network meeting took place. There's a really strong linkage between the Malawi effort on quality of care for mothers and newborns and their overall strategic direction on quality. The WHO handbook that we have mentioned really emphasizes the Pathfinder role that certain quality endeavors can have, and the linkage has to be made very, very early on. And that was a huge privilege to work with our quality of care network colleagues hand in hand over the last 2 years to ensure that there is an emphasis on this interlinkage, which is a really important point, and thanks for raising that.
Thanks very much. Any other questions? I'm going to raise one whilst you're thinking, Shams. I noticed that you very nicely added about this work, these reports covered not only sort of personal service, maternal child health services, but you also mentioned water and sanitation, infectious disease control. And could you give us a flavour? I mean, that's great because I was a public health specialist myself. It's great to hear that. But are the approaches to quality the same or different approaches? Not having read that book, the papers yet.
Yeah, thanks for the question, Bob. And it's certainly a personal area of passion as well. When we are working on quality, both at the facility level and at the national level, I mean, I think the room is full of quality experts, but essentially when we talk about structures and processes for quality, it becomes a little, it becomes a difficult conversation if we're talking about quality in the absence of water, sanitation and hygiene. So one of the things that we have emphasized from very early on is that the work on the strategic level has to be informed by implementation realities. And so if we are supporting a country like Sudan or South Sudan or related to their direction on quality, we need to be clear that the data tells us that 40% of health facilities do not have effective supply of water. Now, we can talk about quality as much as we want. We can talk about national strategic direction on quality, but if we don't address that, then we're really missing a huge opportunity. So we're working very closely with our water, sanitation and hygiene colleagues, both here at WHO and across the various partnerships that have been created for water, sanitation and hygiene, but also making a very critical link with infection prevention and control, as well as the antimicrobial resistance agenda. All, of course, heavily interrelated and interlinked. If you have a chance to glance at the handbook, you'll see an example of water, sanitation and hygiene being used as an entry to understand the linkages with different components of the health system. And again, this is speaking to the point that Jody was highlighting in trying to move away from a siloed approach. It's water, sanitation and hygiene, of course, has a number of different linkage points. And I suppose that's the advantage, but also the challenge of the quality agenda. We can really move into different areas, recognizing that we are gently influencing those pieces of work so that ministries of health and other ministries that are often responsible for water, sanitation and hygiene can take the necessary action so that WASH is clearly embedded in the strategic direction and the governance arrangements for quality.
Excellent. Thank you very much indeed. Any other questions before we move on? Any other points? Anyone online?
So we have a question from someone, Za Tomin from Myanmar, who asks, how can we make sure quality of care is addressed in conflicted affected areas such as the southeast border region of Myanmar and Thailand?
Excellent.
That's a great question. And the reality is that we haven't got an effective and appropriate answer. I think we have to be very humble and honest about that. But also at the same time, from the experiences that we are currently accumulating at WHO, and this is where the linkage point with the 3 billions becomes very clearly evident. If we are talking about emergencies, both acute and protracted. In those circumstances, we need to be placing quite a clear emphasis on quality of care. So give you a couple of examples. So the question is a very specific one in a specific sub-region of a country. In those such situations, there are specific mechanisms to look at the provision of care. Now, an example of that is the HIRAMS methodology. So that gives us a snapshot of what is available and also some considerations on quality. The reality is, and this has actually been highlighted in recent discussions, that there is not enough of a focus on quality in those specific emergencies and protracted emergencies. This is also the case for a number of countries in our Eastern Mediterranean region. So when we talk about Syria, when we talk about Iraq, these situations are crying out for quality considerations when the system is being dealt with both in the response phase, but also in the recovery phase, in the journey to resilient health systems in the long term. And that comes back to the experience related to Ebola. Many of Jody, other colleagues were heavily involved in this space. But for us, we have always emphasized that quality can be a very effective bridge between acute response and longer-term system design.
Great. Thank you very much. Any other points before we move on? That's great. And Shams, thank you very much indeed. That was very clear and excellent. Thank you very much. That's great. And please stay online.
Thank you.
I am now going to hand over to Rashad for the next to introduce the panel for the next session. Rashad.
I'll just take a moment just to let you know and welcome our online audience. We have over 60 people online, so keep that in mind, and hopefully the questions will come through that portal. Be sure to share your questions.
Good morning, everybody. It's wonderful to be here. I want to thank Bob and the HFG project and all the partners for this wonderful opportunity to sit together and review all the progress that has been made in this arena. It's a very important part of the work that we're all doing, and I hope that this joint activity has brought us to a better place than where we were before we started it. And thanks to AID for putting this together. The panel that we are talking about is about specific country experiences, and what we look at are some of the things that have happened in countries, what are some of the institutional arrangements, the challenges, and some of the accomplishments and promising practices that are going on in different places. To do this, we have a terrific panel with 3 speakers on it. And I'm just going to mention who the speakers are, and then we will proceed into their presentations. We decided to do it like this so that it's a little bit less formal, so we can have a conversation and we can have some questions and dialogue afterwards. Our first presenter is going to be Vivian Ado-Kobia, who is the Acting Director of Quality Assurance in the Ghana National Health Insurance Authority, and she's going to talk to us about the challenges and opportunities in governing for quality in Ghana. This will be, so this is a 7-minute max presentation, followed by, and I'm emphasizing the time, followed by Adam Kuhn, who is a governance specialist working at Abt Associates. And he's going to present to us a study of 3 countries in Asia and what they have done in governance for quality. And last but not least, we will have a presentation from Esther Karamagi-Nkolo, who is the Assist Chief of Party in Uganda. And she's going to talk to us about the journey that led to the development of the National Quality Strategy in Uganda. I also asked each one of them if they want to add anything else about themselves. They can do that at the beginning of their presentation, when they start. So with that, and we'll have about 10 minutes at the end for questions and for discussion. So with that, if I can ask Vivian, if you would like to do your presentation, please.
Okay. Okay. Thank you so much for the opportunity to share our key strategies that has been put in place, our challenges and the opportunities that we have as a country in pursuit to achieve UHC in 2030. The National Health Insurance perspective is where I am coming from, and we have 37% of the population that are covered. And the National Health Insurance is a tax-based that we use to finance the whole insurance system. And this 37%, we have 70% of them that come from the exempt group. So we have limited resources to fund. We are facing sustainability challenges. So as a payer, we are so passionate in the quality of care that is being given out there. We are passionate in strengthening governance for quality healthcare. So we have put strategies in place to ensure that the services that are being provided to these insured clients are of quality. We have over 4,000 accredited facilities across the country. So we have instituted quality criteria for these facilities to go through before they can be allowed to take care of these clients. We have trained health professionals in these standards, and these standards were developed together by the broad stakeholder coming from the Church, Christian Health Association, the public, and the private sector. So we all came together. The experts came from these stakeholder groups from all levels of care, doctors, nurses, midwives came together to develop these standards. And these standards were developed in 2009. It was revised in 2014. Initially, it was input-based standards, but the revised one, we have more of processes and more of outcome indicators. And UNICEF has also come out with every mother, every newborn standards. So we have incorporated these standards into our current standards that we use to assess facilities. We look at staffing, we look at quality of care, we look at organization and management. Then we have also incorporated some quality incentives and disincentives into our operations in the form of medical audit, compliance audit. Fortunately, I led in the development and implementation of the credentialing system in National Health Insurance. I also led in the establishment of the Compliance Audit Directorate in the National Health Insurance Authority. So we have medical audits that we conduct once in every 2 years in the facilities that we have accredited. We look at how the facilities are adhering to the standards, are working within the policy framework so that we can have better outcomes, and also we can also sustain the national health insurance. We have also applied quality criteria into the benefit package. We use the diagnostic-related groupings. So based on the resources, these facilities are paid, the resources that are used. So you can keep patients in your ward for 4 days, for 7 days. If it is malaria, it's the same reimbursement that will be given to you. So this will encourage providers to be so efficient and effective in the use of the limited resources that we have. We also invest in quality improvement in some facilities. We have purchased some equipment to facilities that are in need of machines and equipment to provide the quality care. Then again, in pursuit to achieve UHC, we recently launched the National Quality Strategy. This one cuts across all levels of care. So every person, every level has its component so that we can better coordinate all these quality improvement activities. We have challenges. There are disparities in distribution of health facilities across the country. Health professionals want to always work in the cities. So at the grassroots and rural areas, we don't have qualified people to attend to these patients in the rural areas. Then again, we have the standards that are set. When you pass, you are given grades. And these grades can be A+, B, C, and D, depending on how much you scored these standards. But if your facility score A+, and someone scored D, they can all provide services. The same tariff is given to these facilities. So there are no incentives for people to maintain their standards. So it's a challenge. If we want to pursue quality, there should be incentives for those who have these standards up to the level that we have. Then again, there are delays in payment. We owe providers over 6 months. So how best can we do to improve payment so that they can also maintain the standards? There are lack of coordination. Oh, we have so many regulators and organizations. We are all pursuing quality, but everybody has its own standards. Health insurance want to have 4 doctors in a hospital. The Health Facility Regulatory Agency, which I am a board member as well, they also have their standard as 2 doctors. So where are we going? There should be coordination in these standards set. The opportunities, health insurance as a payer, we are so passionate in the quality of care because we want to be sustained. We want patients and we want the population to also have confidence in us so that they can register more, so that we can achieve the universal health coverage. So in the Act, it is stated that we can also come out with quality improvement. So whatever we are doing, the medical audits, the credentialing, we have backing, we have legal backing to conduct these activities. Then also the opportunities out there, we have the community-based health planning and services. This is the lowest level of care. Almost every village has this CHIPS compound situated in. How best can we use this to bridge the gap? How can we support this staff in the rural areas, financially and non-financially, to be able to provide the quality of care that we all need? We have strong political will in pursuing UHC. The National Quality Strategy is being led by the ministry. Last month, the whole ministry went for a meeting to talk about how best we can fairly distribute professionals to these rural areas. So there is this political will in achieving UHC. Then the last one is that we have strong associations. We have Society for Private Medical and Dental Practitioners. We have Ghana Registered Midwives Association. We have Association for Community Pharmacists. They are all there. They are very strong. And the fortunate bit is that when you are developing standards or when you are pursuing quality, they all want to be part of it. They all want to be shareholders. So this is another opportunity that we have so that together we can all achieve the UHC that we want to achieve. So this is what Ghana is doing. We are trying our best. We still have the challenges that I've mentioned. So I'm here sharing so that we all come together to see how best we can pursue the universal health coverage agenda. Thank you.
Thank you. Thank you very much, Vivian. Adam, if you would like to.
Sure. So I'm pleased to be here today to share findings with you from a study that we conducted in Southeast Asia on some of the governance arrangements that support quality. And I'd like to thank Sweta and Jean-Jacques here who have helped us design and support this study in 3 countries. And this is something that lower middle-income countries are really particularly trying to figure out right now. So I'm not going to spend a lot of time talking about the background. We can go over that later. I kind of want to dive into the results with the 5 minutes that I have here. So when we talk about, so the purpose of this study was to look at institutional arrangements that support quality. So we wanted to know what are some of the roles and responsibilities of actors, how can these be linked to purchasing arrangements, or what is the role of the payer in ensuring quality? And then what are some of the lessons that we can share with other countries that are encountering some of these same issues? So what we found, and this study is still ongoing, we're in the latter stages of data analysis. The first country that we conducted research in was the Philippines. And one thing that was really interesting is that we heard from a lot of people that the Department of Health has a strong mandate for overseeing quality. However, they didn't really have a coherent strategy or a long-term plan for pulling it all together. And this was seen as kind of an entry point for future initiatives. And it's something they're planning on addressing, which I'll talk about at the end. And then also in the Philippines, there is PhilHealth, the payer, the Philippines Health Insurance Corporation, is responsible for accreditation. Now, this is problematic, a lot of people saw, because by law, PhilHealth is supposed to use a third-party accreditor. So they're kind of operating in breach of this law. And they're trying to figure out ways, there's a procurement issue, and they're trying to figure out ways to address that now. However, a good aspect of accreditation in the Philippines is it's a highly privatized system, and a lot of the providers, especially large independent private hospitals, are already pursuing the gold standard international accreditation through JCI. And this is really as an effort to compete in kind of a regional market for medical tourism. And providers, as Vivian mentioned, providers at all level in the Philippines are very active. They do things like establish the bench book for accreditation, as well as help establish the case rates for reimbursement. Now, when we moved on to Thailand, the National Security Office, as many of you may know, runs the Universal Coverage Scheme, which has been very successful in increasing access and financial protection across the population. But in the governance structure of the National Health Security Office, there's a Standards and Quality Board. So they have two boards, and one of them is devoted to quality. What's interesting about this is it involves a significant amount of representation from civil society. And that's and a lot of people saw that as if you're starting at the top in terms of your mandate and qualities baked into the governance of the organization, then that'll get you very far. They do other things like they've developed key performance indicators that are pilot tested and differ in different regions of the country in over 50 locations. They developed a set of indicators that are specific to the local context. And accreditation, and then also in the National Health Security Office, they have this complaints hotline and grievance mechanism where disputes can be even resolved in person. And then finally in Thailand, accreditation is done by the Healthcare Accreditation Institute. This is an independent body. And importantly, people noted that it was voluntary and it's focused on process as opposed to outcomes, which was better for facilities, rural or under-resourced facilities, for example. Now, when we move to Indonesia, there's a large-scale health systems transformation. So a lot of these institutional arrangements are in flux. People, it wasn't always clear. Lines of communication, it's also very decentralized geographically and administratively in Indonesia. And so some of this posed communication difficulties, but also the institutional design, what the health systems reform meant for individual actors was sometimes unclear. They have developed performance-based incentives and indicators for payment, for example, and their performance they monitor performance through these mechanisms called quality and cost control teams. Now these are really interesting teams. They're interdisciplinary. They have a number of different types of providers, and they're at the national level, the regional level, and then district and even facility level. So this is one potential mechanism to control costs, but also ensure quality of care and service delivery. So when we look across countries, a number of notable themes emerged. One was that non-financial incentives tend to matter. So in Thailand, for example, there is a Thai Quality Award that's offered by the Ministry of Industrial Affairs. This is a non-health specific award, but it does honor excellence in service delivery. This is in addition to the accreditation award by the Healthcare Accreditation Institute. In Philippines, they're experimenting with centers of excellence. And in Indonesia, there's this Puskesmas Paladin Award, which is people can go through a process of nomination where even at district and at the rural health facility level, excellence in service delivery is acknowledged at even a national level. A second cross-cutting theme is that a lot of people talked about the process of accreditation and as being burdensome and more akin to a clinical audit, whereas the Thai experience, they were very clear that the way the system is designed is for peer learning, knowledge sharing, and it's more focused on process. Now this allows, as I mentioned before, rural facilities that are under-resourced, that have trouble retaining staff, that don't have access to commodities, to not be evaluated or to accredited the same standards as very well-resourced facilities. So they could be more, the focus is on getting them to the next level, so to speak. And then finally, at the end of the day, it all boils down to implementation. So a lot of these institutional arrangements are established, are changing, but there's also laws and policies in place that aren't being enforced or aren't being fully exercised. So for example, some of the shortcomings we identified in Philippines would be rectified through this bill that has just passed the House of Representatives that's currently pending in the Senate. But a lot of our Filipino colleagues were quick to say, yeah, we have no shortage of good laws and policies. The problem is implementing them, as we see with the third-party accreditation there. And in Thailand, people were quick to note that though they've achieved tremendous success in ensuring financial protection and maintaining quality of care, that this potentially overshadows the decades of investment in decentralizing human resources for health, building up the healthcare infrastructure around primary care in the country, which enabled all that to happen. And then finally, in Indonesia, I mentioned these quality cost control teams, for example. This is a potentially good avenue but for ensuring quality at service delivery level. But when we talk to people who were members of these teams, they said, well, yeah, well, they don't always meet, or it's unclear who's on the team, or agenda is kind of fuzzy, so we could use a little bit more support for ensuring that this is implemented appropriately throughout the country. So these are some of the emerging themes that we're seeing in the data now, and I'm happy to elaborate them or to discuss them further if you have any questions.
Well, thank you very much. This is great. Last but not least, Esther, would you like to start your presentation?
All right, thank you. Good morning, good afternoon, good evening, everyone. I'm from Uganda. Uganda is in East Africa. Uganda is the most beautiful country in Africa. It's the pearl of Africa, yeah. Yeah, so make sure you visit. So I'm going to talk about our journey. Uganda is one of the more advanced low-income countries in the area of quality. And this is because it started a long time ago, and there's, one of the partners who was new in the country met me and told me I put out an advert, and there were so many people who came to the interview who knew what a collaborative is. And that was surprising for her. So that just shows you that in Uganda there's skill within the country. So in the mid-90s, this is when the first effort began. It was driven by the ministry. A few experts went for training somewhere and came back and set up a national effort that went systematically through regional and district structures and facility structures to create quality. And it was heavily a quality assurance program. It was branded, eventually known as the Yellow Star program. So if you've been to Uganda, you'll see some facilities have a huge yellow star outside, which means that they won some sort of award for some excellence in performance at that time. Yeah, so that Uganda went through that phase, and a lot of people did that. And then there was a second phase, and these are my own phases. They are not created by the president or anything. Yeah, so the second phase is when donors drove the country towards what was called a quality of care initiative. This was now process improvement in one technical area, that was HIV. So they were trying to close performance gaps in HIV. So a lot of work was done. Of course, URC got involved at that time through several projects, HCI and ASSIST. And what the country did was create champions. What we saw from this era was there were a lot of champions created, people who understood how to do process improvement in such a setting, how to apply the science in the settings in Uganda at all levels, from the community upwards to the huge regional and public, private, and so on. So different initiatives, different people got involved, and then they developed this science in country. And following that, we had a phase 3. This started around 2010. 2010, the government decided to move quality away from one technical area back to the center. So that's when quality assurance department was strengthened. It existed before, but it wasn't in control. Quality was controlled by AIDS control program in phase 2. Now this department expanded and really started to standardize things. So we had standardized trainings, standardized tools, standardized documentation journals, which of course were developed through common conversations with all the partners, local and international, who are doing such work, and what they had and what the country thought they could use. So the main product we saw from this era is standardized. If you enter the country right now and you ask the government that I want to do a quality initiative, they'll have something to give you, some tools, some approaches, some material, and they'll have even people who they've trained, who they can give you to support in a standard way. So what we want to do now is move forward from that, not go backwards. We want to move forward. So I'll just highlight some of the what I think are important concepts in the field of quality right now, and how they advanced in these 3 stages. So the first one is governance structures. We started with, in phase 1, maybe even phase 2, like all countries, there are technical programs. There's maternal newborn child health, there's TB, and so on. So these programs they are developing guidelines. They're trying to improve performance already. So there's something they're doing. So we then moved towards an organogram, a sort of quality organogram created within by the quality assurance people and teams and departments, which had coordination structures, it still has coordination structures at the different levels. So you have a national coordination committee, regional, and the different levels of facilities. So these coordination committees, they provide direction for quality initiatives. They evaluate the quality efforts within their jurisdiction. And so you find that these are the structures within, or someone can use to govern quality. Of course, the levels of functionality vary. In time, sometimes they are more functional than other times, and also geographically. Some regions that are less supported than others will be less functional, and others more functional. But where they the point I'm making is that if you enter, you find fertile ground to start and take things to scale. The second concept I'd like to discuss is patient engagement. Patient engagement, the ministry and the people in charge are very passionate about this. So they've always been trying to find out how to engage patients. So there's some structures. There's one important one is the Health Unit Management Committee. This is a sort of board of governors at each health facility that is made of people from the community representatives. So through this structure, people from the community can come in and have a platform for conversation with the facility and give their opinions and so on. So this exists. There are also others like their suggestion box, and there's a patient charter that gives our information on what are the rights of the patient, what are the rights of the provider, and so on. So there's some effort. But what we are seeing now, as we move towards universal health coverage, is more of conversation. People want to know. People want to create platforms that allow patients to, first of all, make the health system accountable to them, so that they provide feedback, and they also say what they need. Whether the whole aim of this patient engagement is for these patients to use the health system. So we want them to use it. So there's barazas. This is a local word for verandas. So what it means is that people just sit on a community veranda, and it's managed by the Office of the Prime Minister, and speak. The health system is this way and the public is that side, and they have a conversation, and it's facilitated by the Office of the Prime Minister. Then we are also seeing language like health assemblies in the national documents, being encouraged, hold health assemblies. And again, these are structured opportunities for the community, the patients to have direct conversation, not through representatives. And we've also seen more invitations to health consumer representatives and civil society representatives to coordination structure meetings and activities so that also these voices are heard. So this is how patient engagement has evolved throughout these phases. So here I wanted to show you some of the physical things you can find in country when you come. We have a quality improvement strategy. We had the first one in 2011 and the second one, which was revised. We reviewed and found out what was lacking after doing this for 5 years in this strategy and changed for that. A lot of changes were around bringing in more of the other dimensions of quality beyond effectiveness, more patient safety, efficiency, other components into this strategy. Then we also have national conferences. Every year, the country invites anyone who thinks they've done something in quality, whether you're a patient, a health worker, a partner, a donor, into a room for about 3 days, and you share with the rest of the people what you've done, and they learn what you've done, and they make contact. So that's also happening. Then we have a manual. There's a quality improvement manual that puts down the theory of quality, because many of the people will tell you, this is a discipline I don't understand, and I need a specialist. So the government has written down, you can read it. It's like an academic textbook here, quality. Then there's a reporting structure. Anyone can report upwards through the coordination structure, so the government can know and document your effort. Yeah, so we also have, what I've not put here is a knowledge management portal. This is a more recent one. The government has created a portal which is linked to the Ministry of Health website, where you can upload or download anything you're doing in relation to quality. So this is in line with the general knowledge management direction that quality is taking. Yeah, so thank you.
Wonderful. Thank you very much, Esther. So as you're thinking about questions to ask, comments to make, one of the things I'd like to just sort of have you think about is this, that good care happens where the patients receive it. That's, at the front line. This is where, we can tell whether that's good care or not good care. And for that to happen, there's a lot of stars that need to align at that front. But then think of all the different places where patients receive care, and how can you then put these into in a systematic way such that they're addressing the right priorities, they're addressing them in the right way, the evidence-based care that the patient should receive is being received by every patient every time, and how then do you set up a system that can govern all of this in a continuous, dynamic fashion? This is what we are hearing about. And of course, some of these incredible efforts that are going on in the different countries really come as a crowning of multiple years of on-the-ground work, serving patients better and better over time, and evolving that effort from the ground up into what Shem started to talk about, which is the national quality policy and strategy. So now we're not only talking about improvement happening at the front end where the patient receives it, but improvement being driven, being supported, being nurtured from above, continuing to do this. And so with this sort of thinking about how do we govern for good quality and what are the different forms it can take, I'd like to get us into a conversation about some of these experiences specifically and about the broader issues that relate to country experiences and national efforts to improve quality of care. So with that, I'll open it up to you. Please.
Good morning, I'm Dominique Frere. Oh, thank you. Good morning, Dominique Frere. Picking up exactly on Rashad's fine point about patients often come to services from many different providers. So I'd like to touch on a little bit more about the unruly child of the health providers, which is often the private sector. So with all of these strategies and good practice, we know that sometimes the private sector needs some added carrots and sticks to either provide quality data, to engage in quality initiatives, particularly the informal private sector. So what kind of advice could you suggest for bringing in the private sector more enthusiastically into the quality framework?
Thank you, Dominique. Please, who would like to answer this question? Who would like to start?
Yes, we are having challenges with data when it comes to getting information from the private sector in Ghana. Within the regions, we have the regional health directorates. These regional health directorates are managed by the Ghana Health Service, which is public. So some of the private facilities, private owners, they have challenges because some of them think that the directorate is for one particular agency, the Ghana Health Service. So are they mandated to submit their data to them? So people, they are advocating for them to have representation from the Ministry of Health within every region so that it can cover everybody. So when it comes to data, it becomes very difficult. We have 27% of our provider population being private. When you get to the Ghana Health Service, the regional directorate, and you want data, because at times we want to have what actually they submitted at the end of the month, their returns, to match with what is in the facility. It becomes difficult. So at times it gives room for people to abuse the system when it comes to reporting, because you don't have anything to cross-check with what actually pertained in the facility. So the ministry is taking it up to see how best they can coordinate very well with the private so that we can get data to inform policy decision.
Thank you.
I'm happy to also answer that. I mean, when we asked people in a lot of countries about this issue, we really wanted to get at like providers associations, facilities as well, HMOs. We want to get their perspectives. And a lot of people mention that, this is where the strategic direction helps, is aligning the system for more carrots than sticks, for example. Because you want to get facilities to participate and share information, to be open and transparent about their operations. And it's a lot easier to do that if you're doing it through a positive mechanism. So incentives as opposed to penalties. Now, there should be mechanisms in place for any sort of fraudulent care or really low substandard services. But Philippines is an interesting example because it is highly privatized, and one provider explained it to me like this. He said that for example, if your emergency services are overwhelmed because your catchment area has too high a volume, you're going to be in close communication with other facilities to share the burden. So what is a good quality service in terms of responsiveness for the hospital might be good for their competitors, for example, or even public facilities. So they have serious incentives individually to participate. Also in Philippines, they're working, there's some discussion about developing like a government subsidized high cost diagnostic facility, for example. So where private providers could share the burden of these really high-end kind of services. This would be an example, again, to bring them into the fold. And then as I mentioned, a lot of private facilities are already pursuing on their own JCI, international kind of gold standard accreditation. Right, so if they have the money. And Indonesia is an interesting example because a lot of the private sector is these faith-based, primary care organizations, which may not be for profit, they may be for profit, or they may be community-based NGOs, and they're very much looking for assistance and support as they roll out these payment mechanisms and develop kind of decentralized service delivery apparatus.
Yeah, I'll just add a little. The private sector for us is occupying more and more space in the health sector. They are the ones responsible for seeing many of us anyway. So the government has been recognizing them, providing them, including them in the national systems. If there is, for example, the DHIS2, they're expected to enter data. The supervision visits include private sector. So those have been there. However, the government recently released, in recognition of their increasing role, a public-private partnership framework to sort of guide and let people know that the government is in favor of and not against the private sector, seeing them as a group of people who can reach where the government cannot reach. Because if you live in a far-off place and you decide to open a clinic at your home, then you're reaching where the government cannot reach. So the perception of the government is positive towards private sector. However, it hasn't yet taken root. There are many opportunities. There is, for example, subsidized drugs through the joint medical stores that the government can support you to access if you're a private sector partner doing things the right way and so on. There's lots more opportunities that need to be tapped on going forward.
Can I this is an important topic, and maybe could we also talk a little bit about what about the role of patients and patient advocacy organizations in influencing governance and in influencing patients' views regarding the private sector and getting some of that under control? Because at the end of the day, if patients don't go for those services that are poorly governed, then they will fade away. So I know that Uganda is big on some of the patients' organizations. Maybe you could elaborate some on that.
Yeah, so the representatives of private sector and the representative of patients are present in conversations. But I say this type of approach, which is just getting representatives to join meetings, the country is going away from that. So it's more about bringing the people in the community to speak to each other while coordinated by a person with authority. So what we see is that the private sector is also, accountable to the same community. If a patient dies and it's private sector, the community will take those people to the police, and the police will take action. So the private sector is supposed to keep up to date with what the government is saying and adhere to what the government is saying for the public sector.
Anything on patients?
Yeah, our data from Thailand, there's a number of examples of patient advocacy and engagement. One is through, as I mentioned, the National Health Security Office Board. So a lot of the public institutions in Thailand have representation from key segments of traditionally socially excluded segments of society, which is very unique, I think, and it gives them a platform to discuss some of their issues. But in addition to that, people, for example, there was a law for universal emergency services that was recently rolled out. So you can walk into any hospital in Thailand and get access to free emergency care. However, a lot of hospitals were dropping patients or discharging them or referring them after a certain period of time. So they'd admit them and then they'd discharge them right away or refer them on. And so Thailand created a law to prevent them from doing this, for example. And this was again through the media role, so that's a different dimension of civil society, highly publicized cases. But when we asked a lot of people about patient awareness and maybe even a naming and shaming list for facilities and countries, they were very hesitant to go that route because, again, the incentive should be aligned to get facilities and providers on board and not necessarily to embarrass them. And also it distorts priorities in favor of wealthy, large, urban health centers as opposed to poorly performing rural areas that may not, may have severe supply or capacity constraints.
Right. What National Health Insurance is doing to bring these patients on board is that when you register, you are given a small booklet. These booklets contain all the medicines that we reimburse. So, you own it. When you get to the facility and they tell you that this medicine is not covered, you can open the book to tell them that no, it is covered. It is in the book. So that is one strategy. Then again, we have a preferred primary provider system where patients are allowed to select their preferred primary provider. you can move out after 6 months when you strongly feel that the services you are getting from this provider is not what you want. After 6 months, you can move out. Then again, in the standards that we have assessed, we have put together to assess these facilities, we have suggestion boxes in there where facility is a standard. The facility ought to have suggestion box. You ought to have complaints register. And when we come to the facility to assess, we check whether you are using this complaints register, these suggestion boxes are being effectively used, how many times do you conduct surveys within a year, exit surveys. So all these are standards that we look out for when we come to your facility. So we are engaging these patients because we have to bring them on board.
Yeah, if I can pick up on that, actually. We had a workshop in Manila where we discussed some of these findings, and I think Jean-Jacques asked the question of the hotline. I mean, he asked the individual from the National Health Security Office in Thailand, so how many people roughly do you have staff for this complaint hotline? And they said, oh, it's not quite 100, and the other people were like, 100 people devoted to fielding like complaints, and how is this used? And they were very clear that process improvement in Thailand was driven by this process because if there's repeated complaints in facilities or in trends and services, then they can learn from that and then put in place corrective measures.
Hey, can I?
Thank you. Kamyar Kajavi, Management Sciences for Health. I've got sort of a governance and a technical question for you. At least in one of the presentations, there was reference to strong professional associations. Sometimes those are regarded as a bit of a mixed blessing for the health system. The technical part of the question is, in this country for years, there's been a debate raging about risk adjustment and tying outcomes to who's in your patient population and then your payments to that. And I'm just wondering if that's been an issue in any of the countries where you've worked and what the role of the professional societies has been in basically guarding the doctors and the hospital's turf.
Yes, we engage these professional associations. In our audits, the Medical and Dental Council, the Pharmacy Council, the Nurses and Midwives Council, they are parts of the audit. When we move out there, we move out together with them. At times, the registrar for Medical and Dental Council comes together with us to move outside, move into the hindrance to conduct these audits. Again, when we are setting standards, we bring them together. They all have their voice in setting the standards to be used to assess these facilities. We have a lot of stakeholder engagements. At the end of every year, we have our program of work. And this program of work, we have stakeholder engagements in it. USAID is supporting us to also have stakeholder engagements twice a year. So we bring all of them. At times, we make them make presentations for the stakeholders to know what is what they are seeing or what they are receiving. Feedback is given to them. So we engage them a lot, and the feedback is good. I mean, it is helping us to also shape our processes.
Wonderful. Anything else on that?
Thanks a lot. Hi, I'm Gina Holtz with Abt Associates and the Health Finance and Governance Project. 2 questions, just kind of building on some of this discussion. One is around what I call service quality. So we're talking a lot about clinical aspects of quality. But how are you thinking about and measuring and encouraging service quality from the perspective of the client? So waiting times and receiving respectful care, for example. My second question is on the use of case rates or capitation, which can provide a financial incentive to perhaps reduce care or to provide lower cost forms of care. So I'm wondering how you're measuring and encouraging quality when you're using a capitation payment mechanism. Thanks.
Yeah. Who would like to respond to the first question?
Yeah, I'll respond to the waiting, to the patient perspective. Really, we have, as I said, there's a lot of these days skill in Uganda. So the patient's perspective is the way the improvement aims are developed and measured and improvement. So of course the DHIs to the M&E people are measuring the outcomes and the indicators as we know them, but the improvement people, it's usually because the patient will improve if you address their issues. So waiting times, those are some of the aims people work on at the front line to reduce waiting time, and then they develop changes that are successful and go ahead and spread those and share those in the conferences I talked about and so on. So we don't, I mean, it's not, it hasn't had to be a deliberate effort to say that now we are struggling with bringing in patients' perspective and let's start. With the evolution of the science, this is known. Yeah.
Yes, for capitation, we started capitation in one region in the country, and we had listed conditions in the capitation basket. So it was piloted for about 2 years within one region, and it was expected to be rolled out across the country. But there were a few bottlenecks, as you have mentioned. So it has been withdrawn. We are going to go back onto the drawing table to fix the bottlenecks and roll out over across the country. Because some of the conditions, the providers can add 1 or 2 conditions and move it outside the basket and bill. So it was creating some challenges. We thought that we can give the money upfront for you to improve the services, but it wasn't working that way. So it has been withdrawn, and we are working on it. We know it is a very effective payment. It is risk-sharing sort of method of payment. So definitely we'll go back to it, but it has to be done and done very well.
And then did you want to
Sure. So in terms of service quality, I mean, I think this is a critical component. Quality can be ambiguous, right? It means different things to different people. They interpret them in a variety of ways. That's what's really nice to see about the first step in the National Quality Strategy and Plan that Shams mentioned earlier, is that is a country defining a local definition of quality, because then that orients all activities around it. What we found is a wide variety of definitions in the 3 countries. So in the first one, in Philippines, people talked a lot about the patient's perspective. So providers said, when I think about when a patient walks into the facility, what does the waiting room look like? Is it clean? Is there somebody to greet them at the door? Is it an automatic door? Is there somebody holding the door? I mean, it was this more kind of consumer perspective of quality. Whereas from Thailand, it was much more of, I mean, people could cite the WHO definition, for example, by memory. And in Indonesia, people could cite laws and provisions and stipulations that were put in place recently to ensure quality. So there was a different kind of cultural difference across each country. But in addition to that, this capitation and these performance-based payments are challenging. And I think countries take a while to grapple with it. I mean, Indonesia, for example, we heard a number of people say that they've moved to performance-based capitation, that this kind of distorts priorities because it's oriented around the services provided. And so then it kind of distorts priorities potentially away from primary care, prevention, and promotion, and more towards curative care.
Wonderful. Well, with this, I want to thank you all very much. I think this has been a wonderful panel. I thank our speakers very much. I thank you for the great questions that you have asked. And I do want to end it on a note that Shams ended with, which is, in spite of all this wonderful experience and all the learning that is happening, we have so much more to learn about this, and we're just at the beginning of this journey. So I hope that we can continue to learn together and really build this up into a body of knowledge that can benefit other countries. Thank you very much.
So, my name's Lisa Tarantino. I am a governance and finance specialist with the Health Finance and Governance Project for Abt Associates, and I'm here. I'd like to welcome three of the colleagues from countries and institutions and individuals who've been on this journey with us really for the last 2 years. It's really been a pleasure to work with all of you. Paulina Pachenko-Estrello is a director of interinstitutional entailment and follow-up to the International Agenda of Quality in Healthcare in the Ministry of Health. Welcome you. Dr. Pierre Barker is with the Institute for Healthcare Improvement. He is the Chief of Global Partnerships and a Program Officer. And lastly, Gina Lagomarsino is the President and CEO of Results for Development, and she has a deep history in healthcare and also in private health sector in the healthcare and health industry. So without further ado, I'm going to pass it to Paulina to be our first speaker.
Thank you. It's a great pleasure to be here. Thank you for the invitation. So, I can find my diapos. Yeah, I don't have them. Yeah, I don't know if we can. Maybe we can
start with
Pierre.
Pierre. Is that your slides are here, so.
Good. Thanks very much. Okay, so thank you very much for the opportunity to talk here, and I love that introduction from Jody about how this journey has evolved, and really the sense of how many people have contributed to the ideas that are now really coming to fruition. It's wonderful to hear Shams, who's looming over us at the back of the room there, talk this morning about how far this has come, and really the sort of crystallization of all of these ideas. And also the 8 stepping stones, which I think it makes so much sense now to see those, because they have really sort of stood the test of our efforts to help governments. So the work that I'm going to talk very briefly about is the work that IHI has been doing over the last 5 to 7 years, helping a number of different countries around the world who are on this journey to try to transform the way that they deliver health and healthcare and the quality of care. We've been helping them initially with in-country programming, but increasingly as governments realize that they need to get themselves organized to deliver quality.
Your mic is on.
Maybe how about that?
Yes. Fantastic. Thank you.
Okay. Sorry about that. I won't start again. So this has been a very interesting journey for us, because as I say, we've kind of moved more and more out of that. We still continue to work very much in the field, but we realize how important it is for governments to really think about how to get organized, to be able to support their priority efforts to improve health and healthcare across their countries. And so what we did is we went back and had a look at the work that we've been doing, and we focused on 5 countries. And you'll see from the graphic there that it's a combination of low, middle, and high-income countries. And the good thing is that this thinking really applies to pretty much any economy. And as we discussed this morning, it also applies probably to stable health systems as well as unstable health systems. The basic systems thinking, I think, is very much the same. So what we did is we went back and developed a survey together with the countries that we were working on, the 5 countries, which are Ghana, Scotland, Ethiopia, Nigeria, and Mexico. And we went back and just said, like, what happened? What was your experience of it? What was the utility of a national quality strategy? How did it? How was it used in your system, and how did it help you? And so I'm just in the next 2 minutes going to just talk about that. So the first question is, why have a national quality strategy? And I think that the answer that we got, that it really was a very important moment in the quality journey, one that really brought a lot of people together with a common aim, and it was a very important way of crystallizing the health vision of a country. The second was it provided a real sense of direction. There was a lot of aim making when the country said, well, this is what we're going to do. This is how it synchronizes with the rest of our health policy, and it creates a vision that guides decision making. And then the third and very important point is that there's a lot of confusion about quality. What does quality mean? What are the quality methods? And it was an opportunity to sort of stand back and say, okay, well, this is what it means for our country. And we're going to proceed with quality according to, and it was very different in each of the countries. The second was what was actually contained in the national quality strategies that was really helpful. The first part was what is the gap in quality, a real measurement of what's the current state in that country, which is always where we start when we're doing these helping countries with the policy and strategy. Secondly, there's usually in a country something that's driving them towards what is it about this moment in time. In a number of countries, it was actually one single event. In Nigeria, it was a mother after surgery falling off an operating table, which was widely reported because the mother never survived. She had a head injury and didn't survive. So it's a sort of a galvanizing moment. And in fact, in a number of countries, and in fact, it happened in the UK as well, that there was the Mid-Staffs report. The second was a really important component about this was focusing in on the aim, and Rashad, I think, spoke a bit earlier about, or I think it was Shams, about the importance of linking the country's priorities. So getting organized about saying, this is really important, what does it mean to us in terms of our broader goals? And then, very importantly, getting organized about a method, saying this is the way, this is how we're going to frame. Aisha is a huge fan of the Duran trilogy because it's a very important way of organizing thinking around quality. How do you plan it? How do you inspect it? How do you control it? And how do you improve it? And having a system that's not in competition, but is working together, countries found incredibly helpful. We talk a lot about patient focus. This is a great opportunity to really think about putting the patient in the center. But in a lot of our work with countries, we're also talking about the provider. So just keeping both the provider and the patient in mind in terms of taking care. So taking care of the patient, taking care of the provider. There's hugely important linkage to universal quality, universal health coverage, which Shams mentioned earlier. Really, there's a global realization that just getting people to the facilities is not enough. That came out really importantly. And then we had the conversation earlier about aligning the payment strategies. And I think that that's still an unsolved issue around how do you really, there's been this tremendous debate, which I call a distraction, about pay for performance. And allows us to kind of move back into incentives that really matter to both patients and providers. And then finally, the actual technical part about the importance of leadership and stakeholders, some robust structures. I think we're getting quite good at thinking about what is the actual structures that a government can helpfully put in place. And we've heard a lot of it this morning, structures at all levels of the system, from the very bottom to the top. The crucial importance, and it's not often spoken about how do you actually get going. We have examples right now of, someone mentioned the quality of care network. We have 10 countries ready to go and nobody's going. It's, it's just this importance of really just putting a stake in the ground and saying we're on our way. And then finally, something which isn't also spoken about is how do you actually get to sustainability? And sustainability is not a handoff. You hand off something and it's going to crash. Sustainability is working deeply with the country from the very beginning to co-design and co-produce. And so that came out really strongly. All right.
Thank you. Thank you. Thanks very much. I'm sure there are lots of questions, but we're going to hold them while we listen to our next two speakers. Can we move to Mexico now? Okay. We just wanted to build the excitement level for Mexico. And, you know.
Thank you so much. Well, Mexico has a complex, pluralistic healthcare system. I mean, the Ministry of Health is in charge of generating policies, stewardship, public health programs, and health information. But then we have a lot of different institutions that provide services with different resources, different management models, and of course, different results. Under this context, we have great progress in achieving universal health coverage without considering the private sector and social security institutions. We have more than 55 people insured with a package of more than 500 interventions, including specialized interventions such as treatment for different types of cancer, HIV. We have, talking in terms of health expenditure, we have 570 billion pesos. That it's more or less 28.5 billions of dollars. But if we talk in terms of gross domestic product, it only represents 5.9%. No? And from this, we have an important out-of-pocket percentage, more or less 40%. Can I have help? Able to just click through it. Thank you.
Oh, there you go.
Good. Thank you. So the fragmentation I told you before reinforces one of our biggest challenges that are the health results. For example, if we talk about the facilities at state level that receive budget from Seguro Popular, we have a lot of disparities. For example, if we talk about myocardial infarction, if you have an infraction in Zacatecas, you have like a probability to die bigger than 50%. It's a different case if you suffer it in Baja California Sur. This because of lack of resolution of our first level of attention. No? We have identified this as our one of our biggest challenges because, for example, a patient starts feeling bad, he goes to a clinic, and maybe they don't have an electrocardiograph there. No? Or maybe they do have it, but the doctor doesn't know how to read it. Or maybe he just thinks that the patient ate a lot of tacos and he prescribes an antacid. No? So when the patient finally arrives to a hospital, it's too late. No? That also occurs with other diseases like breast cancer, maternal mortality, diabetes, and etc. Some of our successes, we have developed a quality management model that nowadays we are implementing at a national level. We also have essential actions for patient safety. They are mandatory at a national level. In terms of health information, we have a system called Indicas. Nowadays, more than 11,000 facilities every 4 months report their indicators in terms of quality. We have a national committee of quality where all the institutions of the health sector are represented. Then we have at state level a committee, one for each state, and then every facility must have another committee, and all of them must be aligned It's a great example of governance from national level to local level. Then every year we finance innovation projects. I mean investigation projects or management projects. They are submitted by states, and they must be aligned to priority diseases, and they must improve networks between attention levels. Finally, an important mechanism I would like to talk about are our citizen endorsers. They are a mechanism for the civil society to participate in the improvement of quality services. They help us to endorse the perceived quality and dignified treatment. And well, finally, I would like to say that we were very happy to collaborate with the National Quality Policy and Strategy Handbook developed by WHO. It's an important document, and it was very useful for Mexico to participate, and we are very happy to be part of this effort. Thank you so much.
Thanks very much. Leah? Is my microphone on? How do you turn it on? How do you turn it on?
I think they turn it on when you start.
They turn it on for me? Okay. I hope I'll, at some point, there it is. So it's so exciting to be here today, and this has been such a rich discussion. I had the pleasure of being involved in some of the conceptualization of this a few years ago, and I recall back at the time in 2013, we surveyed the Joint Learning Network countries about what their top priorities were and the top challenges they were trying to solve, and quality, the challenge of quality was their number one goal, the number one challenge that they noted. And so I think it was a wake-up call to many of us working with the JLN countries, and a lot of us were focused on sort of helping them solve issues of payment and coverage, and we said we really do need to focus on quality. And what was interesting is at the time, many of the JLN countries were either creating new payer institutions or improving institutions like the National Health Insurance Authority in Ghana that had been just created a few years ago, and adding new infrastructure and architecture to them. And there was definitely a sense that these new payer institutions focused on UHC had a huge potential to really impact quality, and need to sort of learn what those what they could be doing to improve quality. So it's really exciting to see now, fast forward 4 years or so later, and see kind of what some of the countries that were up here before, hearing what Vivian said about what Ghana is doing, what's happening in Uganda, Mexico, et cetera. Many actually testing out new models for figuring out how to ensure that their facilities are accredited and licensed using quality incentives and payment, et cetera. So there's a lot going on, which is really exciting to see. But I'd like to actually be a little provocative today and come back to a question that our colleague in the green shirt asked earlier about the private sector, and note that there are a lot of countries out there that really do have very strong private sectors, countries like the Philippines, Indonesia, Nigeria, Ghana. We talked about a number of these earlier, countries where many, many patients are going to private providers, often small-scale private providers, including poor people, to get a lot of services. How do we actually deal with quality in those countries? We've been talking a lot about investment in architecture in the government for governance of quality, and I'd like to argue that we also need to invest in the governance of the private sector itself, simultaneously, if we're really going to make progress, especially in these countries with big private sectors, with a lot of urbanization, where people are moving into cities and seeking especially curative care from private providers. So let's take a country, just as an example, Nigeria. The latest data I've seen, 38% of Nigerian healthcare facilities are private sector facilities, but 60% of care delivered in Nigeria is delivered in the private sector for various reasons. And most of these are small-scale
providers. Sometimes it's single clinicians, single midwives, drug shops, sometimes a little bit bigger hospitals, but usually not very many doctors or staff. And usually they're very disconnected from each other and from governments. They're really operating alone. Now, ideally, we would like these private institutions to not only be licensed and accredited following clinical guidelines that are developed by many different agencies from the WHO down to specific quality institutions in the governments that they're operating under. We'd also like to see them providing data, as Vivian mentioned earlier, to the public sector. And over time, we'd like to see them get even more sophisticated, right? Potentially over time begin to use electronic health records and information technology to do proactive care management, actually go out and find patients that need particular services and make sure they get them. And also over time create better mechanisms for referrals and continuity of care across levels of care and across time. So we have big ambitions, but getting from where we are right now with a bunch of fragmented private providers to there is a real challenge. And the fragmentation of the private market makes it really difficult for private providers to actually respond to some of these incentives and the monitoring that is being developed by government agencies. They're just too small to be able to do it themselves, invest in these systems. It's also difficult for governments to actually go out and engage thousands and thousands of private providers. They don't have the systems to do this. Many countries don't even have a good list of all the private providers that are in their countries or in their regions, let alone the ability to go engage with them and bring them into the system. So I'd like to argue that there are two things that we really need. The title of this was, what should we invest in? So a couple things we could invest in. One is I think we could invest in intermediary institutions. And what I mean by intermediary institutions, these are in the private sector, networks and other structures that organize groups of private providers into groups and then create the leadership and management systems that are required for strong quality. Pierre just talked about the need for the structures and the systems to do quality management. We need to invest in those in the private sector as well. And the best way to do that is by aggregating groups of small-scale private providers together. These are functions that no single provider can do alone, and they require economies of scale and shared services. And these could become the institutions that are actually capable of responding to the incentives that are being developed by government payers and other government quality institutions. And some examples of these, many exist already. There are faith-based networks. There are clinical social franchise networks. There are provider associations that in some countries are doing some of these functions. Certain countries, chains of clinics are beginning to emerge. You see that a lot in Kenya, in India. So this is happening to some extent already. I was actually with some colleagues from the Health Strategy and Delivery Foundation in Nigeria last week, and they have helped put together a network of 50 providers in Lagos, still relatively small scale for a city like Lagos. But they've brought this group of providers together and begun to create a quality leadership structure across those 50 institutions. And they've actually found that over time there's been a pretty significant reduction in maternal mortality and child mortality among those 50 institutions as they have developed together that quality management infrastructure. They also noted that they've created a different culture among those 50 providers where there's more focus on peer accountability and learning from each other. It's less about a regulator coming in and telling them what they need to do and more about these 50 providers committing to stronger quality and working together for it. I would also like to argue that I think these intermediary institutions could become even more sophisticated over time and develop more functions that are really crucial if we're going to get our health systems to a very high level of quality. They can create the measurement systems that need to be used for ongoing quality improvement. They can also test and scale new and innovative approaches to quality. There's been attempts to use things like decision support software, text messaging, other kinds of information technology to help providers adhere to guidelines. I think a network of providers like this has the ability to test some of those and see whether they work and then scale them up across a broader set of providers if they do work. There's potential for implementing clinical information systems that enable tracking of patient data and then actually proactively flagging when certain patients need care and going out and actually finding them and bringing them in to ensure that they get it. Importantly, they can also become intermediaries of government payment because we all know that in the private sector, typically the kind of care that's getting provided is purely curative care. There's not a lot of preventive care that is getting demanded and paid for by patients, not as much as we'd like to see. So different payment models not only can create incentives for quality, but they can also pay for the kinds of services that might not get provided when you just have a pure fee-for-service model. There can be opportunities to create patient feedback mechanisms. Some people in the last panel talked about those sorts of mechanisms. I think many of them were probably referring to the public sector. It would be good to have those in the private sector as well. And then eventually, over time, developing the kind of referral networks, even over levels of care that are all within particular networks. And we've seen that happen in a few countries. I'm thinking of the World Health Partners Network in India that brings together local formerly informal providers and connecting them through telemedicine to physicians in larger cities so that they can provide care on a remote basis to patients. And then there's also secondary facilities that patients can get referred to for procedures if they need it. So they've really thought about creating a whole network of private providers at different levels, utilizing existing players in the system. But too many providers right now are operating outside of these networks. So my second recommendation would be that the payers, the national payer agencies, think of themselves not just as payers and regulators, but also as shapers of the market. That part of their goal is actually to shape the way the market evolves and not just figure out a way to pay the providers that are already there. They can work to proactively defragment the private market so it can better respond to these incentives. And a few ideas for how payers might become more strategic purchasers to shape the market would be to do more proactive private market assessments to see what actually exists. There's a lot that can be built upon. But also to really understand what the needs are. They can convene stakeholders. We discussed how there are a lot of stakeholders that are interested and engaged. Can we convene those stakeholders, including the private sector, civil society, and patients, to actually think about what the future health system of the should look like? And be inspired by some of the innovative models that we're seeing around the world, like the World Health Partners model, like Kaiser Permanente here in the US. That's a very advanced model, but it's helpful to see where you might be aiming. The Center for Health Market Innovations lists about 1,000 different innovations happening around the world. We can be inspired. And the payers can be considering creative contracting models to engage with private providers to help incentivize the creation of those networks. And they might even partner with donors or with impact investors to provide upfront capital to start up those networks. And then the payer over time can be the one that actually provides revenues to cover patient care. So there's, I think, many, many things that payers can be doing. We might look for inspiration to the Centers for Medicare and Medicaid here in the US, which has created a whole innovation center which is designed to really shape the market, create accountable care organizations, and it's just changing the conceptualization of what a payer does. So I'll just close by saying I know that this stuff is not easy to do. There's a lot of, there's politics around trying to reshape the market. Engaging private providers can be tricky. But I think it's worth trying, and I think we do need to also focus on governance structures in the private sector in addition to all the great work that's being done in terms of governance structures in the government. Thanks.
Thanks so much. Before we turn to questions in the audience, actually, Gina, you had some wonderful examples of some promising practices, even with some measurable successes. I'd like to turn that actually to the two other panelists to ask, in your experience, is there anything that you've seen that's been particularly successful? I think we do naturally focus on the challenges and the difficulties, and I was thinking about Esther's presentation. While there's been a lot of successes in Uganda, it's been a 25-year process, and along that way, I'm sure there are measurable things that happen that really boosts the work towards quality a little further. So,
okay. Well, personally, I think that it's really important to focus and prioritize efforts. Second, to invest in human resources, and don't forget the primary level of care. No, if we don't have a good primary level of care, we have anything, and no budget will be sufficient and sustainable. No, and finally, to have mixed schemes from top down and bottom up approaches, I think it's also useful.
So I think the biggest opportunity for a breakthrough is, and I think the donors can really help to drive this, is to get out of project mode and to get behind government and private sector efforts to improve care. And I think that what we've seen is, and I mean, we're all guilty, of promoting our own favorite models. But there are, in every country, there are existing administrative structures. In the private sector, there are these very well-established faith-based networks, franchises, and other pre-existing mechanisms. And I think providing the existing structures, administrative structures, with the tools to be able to improve systems is how we're going to break through. It needs design thinking, it needs building capability, and it needs learning systems, which by definition really need a lot of improvement in the current data systems, because you can't do this work without better data. But I think this has to be built from the ground up. We can't build things and then hand them off. These have to be co-created, co-built, but I think there's so much existing infrastructure that we can work with that I think is just not being used.
I couldn't agree more. I mean, I think there's a lot of, we get very caught up in what specific interventions work, and sometimes we like to do, research to understand, did this work or did this not? Let's do a study. But I think this notion of, there's a need to create institutions in countries that are led by government, but that are very much engaged with all the different stakeholders, civil society, patients, private providers, that do this work on an ongoing basis, that are consistently measuring, setting standards, looking around the world for innovations, and then figuring out if they can bring them, pieces of them, adapt them for their own context. And so creating the institutions that can do that on an ongoing basis, I think, is the most important thing that we can be doing. And I agree that if we're in project mode, it's hard to create ongoing institutions.
So as much as I would love to just keep talking and asking more questions, I'll open it to the other participants here. Yes, ma'am, in the back.
Thank you very much, Kathleen Hill with the Maternal Child Survival Program, and thanks to all the panelists before and now. These are really interesting discussions. I just wanted to come to the topic of today, which is governance and quality, and in particular, as we're talking about public versus private sector, I'm wondering, I'd be interested to hear the panelists, do we really need to create such a dichotomy? Because, for example, in Nigeria with the Quality of Care Network, we're seeing networks of private and faith-based and public facilities coming together regularly, visiting each other, learning from each other's strengths. And so I'm wondering if we don't potentially, do ourselves a disservice when we're thinking about governance and quality to sort of create these polarized groups. And I'm also thinking of the US, where it's, Kaiser works all the time with private institutions and state institutions, et cetera. So I guess it's a question, so I just wanted to, we don't have to answer it right now, but just some of the reflections about as we're thinking about governance and quality going forward.
Yeah. Well, would anyone else like to respond?
Maybe just very briefly, I absolutely agree that there shouldn't be a dichotomy, but I think right now the challenge is for many small-scale private providers, they have no mechanism right now for actually even engaging in any of these activities. There's not, if you are a single midwife practice, you're probably not, you don't necessarily have the infrastructure to do that. And I think creating some sort of quality infrastructure and management structures that has the ability to engage private providers, and maybe both at once. Maybe there's a potential to create networks that include both, and I think that's happening to some extent in Ghana and other places. Yeah. So anyway, I agree that, but I think we need to focus on some of those providers that have been left out of that.
Thank you.
Yeah, I would also mention, I mean, we're really focusing on low and middle income countries, but we work in middle income countries where the private sector is leading the way and is supporting the public sector. So both in Brazil, well, Brazil would be the best example, and in South Africa, in fact, we worked with the private chains of hospitals on condition that they would support the public sector. And they did. They buddied up with public hospitals. It was incredibly successful. The private sector in Brazil is leading major national collaboratives in the public sector. And so I think we need to think both ways as well. And certainly in low middle income countries, the private sector needs support. And it potentially could happen in the same way.
Well, in the case of Mexico, actually we are starting works with the private sector. For example, we have a lot of physicians that works at pharmacies. They have their consultorio.
Like a consultation room?
Yeah, consultation room in every pharmacy of the country. So nowadays are giving more attention to patients than all the public sector as a whole. So we are trying to invest in them so they can be well-trained and help the public sector to detect patients, for instance, with diabetes or obesity at a good point, not to wait until they have complications, no? So we are working with the private sector in that terms.
And just quickly, I'll be looking forward to the results of the study of the 3 Asian countries. I worked in the Philippines for a while with PhilHealth and small private midwives who were, exactly as you described, but the midwife associations were engaging them, and also PhilHealth came out with standards and a real reliable way for them to get income, which is having poor and low-income women come and use their insurance. And I saw clinics make changes in order to get that accreditation that would really help with infection control and emergencies. So anyway.
I think we're at good time.
Okay. Oh, okay. I think.
Maybe one more question.
Okay. Okay, one more question. Yeah.
Thanks for your presentation. My name is Li Yang. I wonder if you can sort of compare those countries you are trying to help improve the quality of care and in the United States. In the United States, you are saying very developed, everything is wonderful. But the problem, you also heard that healthcare costs in the United States is much higher than any other in developing industrial countries. So I was wondering, is there any mechanism you can sort of set up and control in those countries, or they will not have following the footsteps of the United States?
Thank you. That's a good question.
Yeah.
Thank you. Thank you. Okay. All right. Well, if anyone has the, I think we're good with the, yeah.
Now the problem is in the United States, maybe they think if you depend on government is printing the money, so everybody is sort of greedy, and a lot of pharmacy and a drug company, they are raising up high, and physicians, they don't care about health care, but in the record is a lot of care. Okay. So I just wonder, do you have that kind of mechanism or those reliability or real care and the data?
I would just say the last thing anyone should do is try to emulate their country's health system based on the United States of America. It's a mess. I think the only point I was trying to make is I think there is a payer agency here that's trying to correct some of the challenges of the high costs of care and low quality by trying to create incentives for the private market here to shift. And so they recognize all the challenges, and they're looking to see if they can make those changes. But we're very, very, very far from having been able to achieve that here. So, yeah.
Well, thanks so much. Before I just wanted to, a couple more words. there's been a little bit of reference to the definition of quality, and I'm not going to get into that now, but governance is a similar term that people debate about what do we mean by that. And it just reminds me of how far this whole body of activity has come, where years ago we were really focused on what do we mean by governance of quality, where I think practitioners and policymakers understood intuitively the link. And now we have the definitions and the research and the active engagement and even the mechanisms through the Global Learning Lab and JLN to really continue that research and learning and strengthening of governance for quality. And I wanted to thank the three of you and the other colleagues who've been working on this for so long for your contributions. Thank you. Thanks so much.
Well, thanks very much, everybody. We're over time, so I'm going to be very quick, few closing comments. I think you'll all agree that's been a very rich 2 hours. I've certainly learned a lot in the last 2 hours. It's been terrific. So just a few closing points. I mean, the point that I think was made earlier on from Rashad and Shams about that we started on a long journey and we've learned a lot, but we've still got a long way to go. And I think we're just learning, even in the last 2 hours, I've been learning so much more. It's nice to hear that we're part of a global movement, what's happening in WHO, and this is actually a growing sort of realization about it's not just enough to get services to people, they have to be of quality, and the movement around national quality policy and strategies, it seems like it's a growing momentum, which is terrific to hear. But my final takeaway from that is that you learn so much by listening to countries. I mean, the people, listening to Ghana, Uganda, Mexico, and the research from Asia, it was terrific. You get into the details, and that's where the learning really comes out. So I'd just like to say that it's great to hear that Joint Learning Network started this conversation a few years ago, and I'm sure that will be carrying on for many years to come, together with the network run by WHO. And I'd like to thank the panelists, the organizers, but particularly Jody and USAID for bringing us all together and showing that actually together we can continue to learn and in such an enjoyable way. So thank you very much. And a round of applause for all the panelists. Thanks, Rich.